Hey guys, today we're going to talk about menopausal hormone therapy and the impact on bone health, specifically osteoporosis. This is also another confusing topic for many prescribers, practitioners. The data has been mixed for so long, but we have newer studies that actually make the evidence a bit more clear. Estrogen used to be recommended for heart disease prevention, for stroke prevention, for cholesterol treatment, and that data didn't pan out. Estrogen was shown to actually worsen these risks. The data is also similar for osteoporosis. Estrogen was used to treat and prevent osteoporosis. So today we are going to walk through the following: why estrogen matters for bone health, what the Women's Health Initiative actually showed in terms of results, who benefits the most, why estrogen is no longer considered first-line therapy for osteoporosis, and when estrogen is enough to protect bone. Let's get started. Before I begin, don't forget to give me a thumbs up, share this material with anyone you think may find it helpful. This helps me reach a broader audience. How does estrogen impact bone? Most women will reach menopause at an average age of 51, and when estrogen levels fall, bone resorption, the breaking down of bone, goes unopposed. I have discussed in a previous video osteoclasts and osteoblasts and how there's bone resorption and bone building, and with a fall, the loss of estrogen, bone replacement slows down. A woman can lose up to 5 to 10% of her peak bone mineral density within the first few years of reaching menopause. Estrogen does help maintain bone mass by a variety of mechanisms. Number one, they suppress osteoclastic activity, the cells that break down bone. They maintain calcium balance, and they also support bone remodeling. We're first going to talk about why menopausal hormone therapy is no longer used as a primary treatment for osteoporosis. Before the early 2000s, menopausal hormone therapy was used to prevent osteoporosis. We already know that hormone therapy was used to treat other disease mechanisms such as stroke, clots, cholesterol, cognitive impairment, and heart disease. The Women's Health Initiative studied oral equine estrogen at 0.625 milligrams with or without medroxyprogesterone at 2.5 milligrams. The participants were older on average with an age of 63 to 64. In these women, the combined estrogen and progestin regimen increased the risk of coronary heart disease, stroke, venous thromboembolism, which are also known as blood clots, and increased the risk of breast cancer, while the estrogen alone increased stroke and clot risk, but not breast cancer or heart disease. Because we now have safer estrogens and transdermal estrogens, we've got micronized progesterone medications. The effects are more favorable, but we actually choose targeted therapy for osteoporosis with least of those systemic side effects, such as SERMs and bisphosphonates. Those are the first line for osteoporosis. So let's talk about the timing hypothesis, which I've mentioned before. Do younger postmenopausal women experience a more favorable effect? A key point in the follow-up of the Women's Health analysis is that age did matter. Women who started menopausal hormone therapy before the age of 60 or within 10 years of menopause actually were found to have different results. These newer formulations have a more favorable cardiovascular and thrombotic profile, meaning less heart disease events, less blood clots compared, and we're talking about transdermal estrogen and micronized progesterone in contrast with a conjugated equine estrogen and medroxyprogesterone of those older trials. So younger women using menopausal hormone therapy for vasomotor symptoms like hot flashes actually had an additional bone protection. But theoretically, how does estrogen prevent bone loss? Well, we have a few trials that demonstrate that. We have the percutaneous 17 beta estradiol trial, where they looked at 43 postmenopausal women and they were randomized to estrogen, calcium, or placebo. And they found that in the estrogen group, they had forearm and whole body bone mass that was better preserved than the group that had calcium or placebo. They had better preserved spinal bone mineral density as well. There's a second trial that they looked at called the estropipate exercise trial, where 120 women with a low bone mineral density already were randomized or placed into an exercise program with placebo or calcium or estrogen. And they found that the estrogen group with the exercise actually had better bone loss reduced more effectively than the other groups. We've got dose studies that looked at 17 beta estradiol and esterified estrogens. All the doses prevented bone loss. Higher doses, in addition to lower doses as low as 14 micrograms per day, had a benefit in preserving bone mass or reducing bone loss. And then there's the estradiol group versus placebo, and even women with very low doses of estrogen were found to have a higher bone mineral density than the placebo group. So the biology is pretty strong, and the clinical data consistently confirms that estrogen preserves bone mass. Okay, so does estrogen lead to a difference in fracture outcomes? Because that's what matters. Bone mineral density is just a number, but it's the fractures that patients and doctors are really concerned with. Well, the data is promising there. The best evidence comes from the Women's Health Initiative. Even though the Women's Health Initiative wasn't designed to study osteoporosis, they actually discovered and studied the effects. Hip fracture risk was decreased by around 34%. Vertebral fracture risk also reduced, and other osteoporotic fractures also were reduced. This is in the combined estrogen progestin group. In the group that received unopposed estrogen, they found that hip fractures also reduced, and so did vertebral fractures. So yes, estrogen does reduce fractures. But does the estrogen preservation of bone mass stop if the estrogen stops? Well, the question is also debated because there's been mixed studies. Some studies show that bone loss is accelerated as soon as the estrogen is stopped, whereas others do not. Women who ever used estrogen tended to have a higher bone mineral density compared to those who didn't. So while stopping the estrogen may lead to some catch-up in bone loss, you do not lose all the gains. What about if the woman already has established osteoporosis? Does estrogen play a role there? Estrogen is not a first-line therapy for osteoporosis. We favor agents that are already established and have strong benefits in preserving bone mineral density, in addition to reducing fracture risks, such as denosumab, bisphosphonates, and anabolic therapies such as teriparatide. But in some cases, for women who are already taking estrogen for menopausal hormone therapy and for menopausal vasomotor symptoms like those hot flashes, fatigue, and mood disturbances, the estrogen may be sufficient to maintain bone density. The bone density still needs to be monitored, especially if you're at risk, and additional medications may be needed. But studies did show that estrogen does increase spine and hip bone mineral density and does reduce vertebral fractures by much as even 50%. Again, this is a standard approach, but each patient's situation is individualized. And when it came to estrogens versus bisphosphonates, the head-to-head trials actually showed mixed results too. Estrogen was similar to alendronate in some trials. Alendronate's a very common bisphosphonate, but it was found to be superior in older women. Combination therapy improves the bone mineral density more than either alone, but it does not improve fracture outcomes. Therefore, the bisphosphonates are usually recommended over the estrogen in women who already have osteoporosis. What about progestins, the ingredient that we give to postmenopausal women who have a uterus? Well, progestins actually showed a weak benefit in preserving bone mass as well. It doesn't exceed bisphosphonates in terms of therapy. So here are our key takeaways and what clinicians recommend. Estrogen does prevent bone loss. Estrogen also reduces fractures. But estrogen is not first-line therapy for the treatment of osteoporosis. Younger women on menopausal hormone therapy for menopausal hormone vasomotor symptoms like those hot flashes have added skeletal benefits. Ultra-low dose estrogen, such as in transdermal estrogen, still helps preserve bone. First-line treatment for osteoporosis remains bisphosphonates and other anti-resorptives. If you like this material, give me a thumbs up and subscribe. I'm here to make the medicine make sense. Until next time.